thank the audience for joining us in this scientific meeting dealing with asthma. I will be sharing my slides. And I think before I start, there will be some poll question, or that will be left to the end.
Yes, we can start by polling question number 1, please, if we can launch it to the audience.
Okay. So I'll stop sharing from my side.
Yeah, you can still be sharing. It's fine. The poll will be appeared to all of us, even if you are sharing.
Okay.
So for the first, not this one, not the 13, number 1, please. So what do you think, for the first question, what do you think of the primary goal of asthma management? If you can launch it, please, team. What do you think is the primary goal of asthma management according to current guidelines? One choice. So you can choose one choice only. Is it reducing disease severity? Is it controlling airway inflammation? Is it preventing infection or managing comorbidities? If you want to prioritize one, what would it be? We'll give it 20 seconds and then display the answers and then go to the questions, because we'll go back to the answers after the presentation. So after like 20 seconds, please, team, if you can close the poll and share with us the results that we will discuss after the presentation as well. So most of the people shared that is it between reducing disease severity and controlling airway inflammation. Very interesting. Next question, please. At what stage of asthma treatment do guidelines recommend an anti-inflammatory approach? Is it in initial stages only? Is it in all stages, or is it is in severe asthma only? And what about the answers? Can we see the answers? So most of the people said all stages, and the second is severe asthma only. The third question, before giving the floor to Professor Idris, please. Treating dual inflammatory pathways in mild to moderate asthma leads to no significant change, better symptom control only, better inflammation control and asthma outcomes, increased side effects. So, what does treating dual inflammatory pathways do in moderate to mild to moderate asthma? Also, please, team, give it 20 seconds and then let us see the results. Let's check together. And then better inflammation control and asthma outcomes as expected. Now, the floor is yours, Professor Idris, to give us the updates from your side.
Thank you so much. So start talking about asthma. So this is my disclaimer. And really, I believe that really our journey with asthma started it long time ago, and we learned a lot during this journey. So our journey started back on the mid '90s, when at that time we believed that asthma is just a smooth muscle disease that needs just like smooth muscle relaxation and a bronchodilator. Now, in the 60s, we started talking about airway hyperresponsiveness, but it was only in the 70s, based on autopsy studies, we start understanding that inflammation is the hallmark of asthma, and it is the cause indeed of the bronchial hyperresponsiveness. And believe it or not, only in the early 80s, based on bronchoscopic evidence, we have very strong information indicating that inflammation is the cornerstone of bronchial asthma. So our, our current understanding of asthma that it's chronic inflammatory disease of the airway. This chronic inflammation lead to increased airway hyperresponsiveness and lead to the clinical triad of wheezing, cough, and shortness of breath, leading to airway limitation that is usually, not always, usually reversible with treatment. So inflammation, to start with, is the cornerstone of bronchial asthma. Now, before we start, we need to start understanding certain terminology, because sometimes we kind of mix between uncontrolled asthma and severe asthma. Now, the word uncontrolled asthma means nothing, means that asthma symptoms control and exacerbation are not met. Whether this patient is on treatment or not on treatment, it does not matter. Just like this patient has a lot of symptoms and a lot of exacerbation. Now, the word difficult to control asthma is a bit different. It indicates that despite treatment, what looks like appropriate treatment, this patient is not controlled. Now, this could be because of many reasons. Of course, one of them could be that this is severe asthma and need more escalation of care, but it could be only basically also related to the really poor compliance, bad adherence to treatment, comorbidities, etc. Severe asthma, on the contrary, it is a genetically predisposed disease that is in some patients, about 4% of asthma patients, that they have genetically determined severe asthma that required multiple medication to bring asthma under control. So despite or irrespective of the severity of asthma control is the goal of therapy, whether we are using one drug in mild asthma or three or four drugs in severe asthma. Our goal is to control asthma. And if you look at the GINA guidelines, now GINA guidelines define control based on two domains. The domain of symptoms, that you would like the patient to have no daytime or night symptoms, no need to use a lot of rescue treatment, and no exercise limitation. But also, they would like to emphasize that the future risk, i.e., mainly exacerbation, abnormal lung function, or side effect of the medication, goals are achieved. So we're usually look for the current symptoms control and prevention of exacerbation and maintaining of the lung function in asthma patient. Now, the question always asked that how are we doing at the moment with our asthma patients? So this is the INSPIRE study, which was done in 8 European countries, trying to look at asthma patients on treatment, how they are doing when it comes to the asthma control. And as you can see, that only 30% of those patients were well controlled based on the GINA guidelines, indicating that they have good symptoms control and no future risk. 20% were partially controlled, and 50% of those patients were actually uncontrolled. We have a study in Saudi Arabia using asthma control tests. So really, this study was done in Riyadh City in four tertiary care hospitals, and found that only 5% of patients with asthma can score more than 20, i.e., that their asthma is well controlled based on the ACT questionnaire. And as you can see, that 30% were partially controlled, and about 60% scored less than 16 points, indicating that their asthma was not controlled. Very similarly, we conducted a block survey in Saudi Arabia looking at about 1,500 patients on treatment and ask them about their symptoms during daytime and nighttime, the use of SABA and exercise limitation. And again, you can see that the message is very repetitive, that about 70 to 80% of those patients had some trouble when it comes to asthma control. So the question to be asked is why is that? Why our patients, despite the adequate medication that we have, they are not adequately controlled? Is it like because of low use of controller therapy, management guidelines not followed, limitation with therapy technique and really administration, presence of comorbidity, or inadequate addressing of the phenotyping and endotype? And many studies have shown that asthma patients globally, they kind of tend to not to use their inhaled steroid regularly. They more and more depends on, if you like, on really rescue treatment, the bronchodilator. And this is irrespective of the degree of asthma severity. The patients with asthma do like their reliever therapy more than controller therapy. Another study tried to look at what is the actual use uh, uh, of inhaler therapy in all asthma. So this was 24 patient study trying to be looked at. And what the author concluded that only 30% of those patients will be compliant and adherent to their asthma treatment. So definitely, whenever we have a problem with asthma control, the first question should be asked, are you using the inhaler? And do you know how to use the inhaler? That's extremely important. And when we talk about the inhaler, we are talking mainly on the controller treatment. Now, look at the GINA guidelines, trying to look at the steps of care, whether you are using the preferred basically tracked or alternative basically tracked. You would see that inflammation or really anti inflammatory treatment starts at step one and ends at step five, depends on the level of asthma control. We can start in the preferred tract with using ICS formoterol as needed, and then we can build up the dosing, plus adding another controller until we use biological therapy in step five. And that's also true when we go to the alternative controller. So really, anti-inflammatory treatment should be used in all step of care of asthma, uh, whether they have a mild uncontrolled to very uncontrolled asthma. And of course, we know that the cornerstone of using controller therapy in asthma are ICS and LABA, which is long-acting beta agonist. Based on many, many studies, including Greening study at the Lancet, when they look at patients who were not controlled on low-dose inhaled steroid, and they were randomized to increase the dose of really ICS versus keeping the dose low and add LABA, and found that adding LABA will have better outcome when it comes to the symptoms control and to the lung function improvement. So now all guidelines recommend adding treatment rather than increasing the dose of the inhaled steroid. So after a week, we kind of concluded that ICS LABA is very, very important in those patients, but we need to remember one thing, that LABA, although it has some synergistic effect with the inhaled steroid, by itself, it is not anti-inflammatory therapy. It is a bronchodilator therapy. So question we're always asked, are we missing anything? And the question is, especially those patients who have mild to moderate uncontrolled asthma, are we optimizing the really anti-inflammatory treatment? And we know that in those patients, they do have two main, if you like, pathway of inflammation. We have those who have mainly cytokines and those who have leukotrienes. And some of those patients, they have mixed, basically upregulated inflammatory process that need to be addressed. And we know that if you use inhaled steroid, which is very good in controlling most of the cytokines that are present in asthma, but do not significantly affect the leukotriene pathway. And we know that if you want to really block the leukotriene pathway, which is more common in children and in young adults, but it can also present in those patients who have some comorbidities, basically including uh, really allergic rhinitis or rhinosinusitis. And we know from many, many studies that the level of leukotrienes increased with the asthma severity. So basically, the more severe asthma, the more leukotrienes is basically increased in those patients. And we know that using steroid, whether you are using really inhaled steroid or even systemic steroid, have very, very minimal effect on the leukotriene pathway. Furthermore, studies have shown that even in those patients with mild asthma, whether we are using anti-leukotrienes, montelukast, or inhaled steroid, we can decrease inflammation as really measured by blood eosinophils significantly. But it seems that when we use both drugs together, you get an additive or really synergistic effect, and you can have better control of the inflammation. And to address this point, there was always question about those patients with mild to moderate asthma who have no adequate control on the inhaled steroid. And the question came, should we doubling the dose of the inhaled steroid or add anti-leukotrienes? And looking at the compact trial, it was a fascinating study by David Price, trying to look to answer this question. If somebody with mild to moderate asthma not adequately controlled on inhaled steroid, low dose steroid, should we double the dose of steroid or add montelukast? So those patients were randomized to receive either the double therapy or to have a placebo of one of those medication. And what they find out that when it looks at improvement in the lung function, whether you double the dose of steroid or adding anti-leukotrienes to the low dose steroid, there was no difference when it comes to the improvement in the lung function, no much difference in the quality of life, and no much difference when it comes to the fact that there was control of the night and daytime symptoms. However, however, when they look at subgroup analysis to those patients who have asthma and allergic rhinitis, so now you have an upper and lower airway disease, it was clear that adding anti-leukotriene, montelukast, was better than simply doubling the dose of steroid in asthma outcome, including lung function. So it seemed that if you have a patient who have asthma and allergic rhinitis who is not adequately controlled on low dose ICS, the better treatment for those patients is to add montelukast that can control the nose and help in controlling the lung as well. So, what about the second question? If now we have a patient who's not adequately controlled on low dose ICS, should we add LABA, which is the standard of treatment as based on the guidelines, or actually we need to look carefully whether some of those patients might benefit from adding anti-leukotrienes? And of course, we know that adding LABA has tremendous advantage, as per Greening study and other studies showing that adding LABA to ICS, improving asthma symptoms, improving lung function, and improving asthma control in general. And many, many studies have confirmed that. But there was also a concern from the other side that maybe if we just using LABA to those patients to improve symptoms and lung function, are we masking the underlying inflammation that's not adequately controlled with really inhaled steroid? And we know that from Nelson's study and the other study that those patients who really received LABA versus anti-leukotrienes, and if you'd like to look at lung function per se, LABA was superior than anti-leukotrienes in improving lung function in those patients. And that was not a surprise because LABA is a bronchodilator. However, when you look at the effect of LABA on the eosinophil in the blood or in the sputum, you can see that adding LABA to inhaled steroid did not actually make a lot of difference in reducing the eosinophil. This is unlike when you add montelukast to the inhaled steroid, that you can see now that the inflammation in the lung significantly reduced, irrespective of the clinical outcomes such as lung function and symptoms. So the impact study tried to answer that question in more detail, trying to see which one is better in those patients. Should we add montelukast to the inhaled steroid, or should we add LABA? So again, a patients who were not adequately controlled on low dose ICS, they were randomized to receive either low dose ICS uh, with montelukast, or low dose ICS with solmeterol LABA. And they follow those patients for about 48 weeks. Now, when it comes to the asthma exacerbation, uh, there was no difference whether you add LABA or you add montelukast in those patients, trying to look at night symptoms. Again, both were adequately controlled by either using LABA or adding montelukast. Very similarly, when you look at the quality of life, there was no much difference in those patients. However, the only difference was again noted when you look at the sputum eosinophil as a marker of inflammation, that those patients who were on LABA, there was no significant change in the eosinophil. If anything, there was a little bit increase in the eosinophil. However, those patients who were treated with montelukast and inhaled steroid, there was further 40% reduction in eosinophil, indicating that this really anti-inflammatory treatment using the dual pathway of really blocking the cytokines and the leukotrienes does work in those patients. Finally, what about those patients with severe asthma? And now we are in the era of biological therapy where we need to start using treatment different than the standard treatment of ICS, anti-leukotrienes, LABA, and LAMA. And, and the beauty of the really biological therapy, very similar to the dual pathway, we need to start to understand more and more the really endophenotype, the type of inflammation in those patients, and whether we are using in that patient which inflammatory pathway is the main active pathway. Is it the high T2, basically low T2, or those who have just basically neutrophilic asthma, structural remodeled airways? Which pathway is really active? Is it like basically mostly allergic? Is it mostly eosinophilic? Is it really combined allergic and eosinophilic asthma? So we need now to start understanding the nature of the inflammation in those patients with severe asthma. And we know that at the moment, with the current biological therapy trying to target the most active inflammatory pathway, has led to dramatic improvement in the outcome in those patients who previously were unable to get adequately controlled with the traditional therapy. So, for example, we know that using anti-IgE omalizumab in those patients who have type 2 asthma, predominantly allergic severe asthma, using omalizumab has led in multiple studies, such as the Busset and Soler study, to about 50 to 60% reduction in exacerbation in those patients. Very similarly, trying to target the anti-IL-5 pathway, and you know that really the IL-5 is the dominator for the eosinophilic synthesis, really basically maturation and effect really on the lung. So using anti really basically IL-5, whether this is beralizumab in the Sirocco and Kalima, or this is amipolizumab in the DREAM study, has led to significant reduction in exacerbation in those patients and significant improvement in asthma control. Dupilumab was really tested again in patients with moderate to severe asthma, not adequately controlled, exacerbator patient, and found that this drug, the dupilumab, that target anti-IL-4, anti-IL-13, again with a high T2 asthma, basically pathway, found that this drug again reduces exacerbation, improve lung function, which was the primary endpoint, and decrease the use of the oral steroid. Finally, we have really tezepelumab that work on the anti-TSLP, which is the most proximal alarmin that is released after the really irritation of the epithelium, and using anti-TSLP treatment, tezepelumab, has led to significant reduction in exacerbation in both patients who have high T2 and low T2 asthma. So now biological therapy has moved to be from not only basically supportive, but they are the main treatment for those patients with severe asthma that are not adequately controlled in multiple treatment, which we used to call the standard of care, ICS, LABA, LAMA, and basically nicotine treatment. Finally, now we are moving a little bit more than just controlling asthma. Because if you look at the previous definition of asthma control, it was talking about controlling symptoms, preventing exacerbation uh, over 3 months period. Nowadays, we moved a step ahead, and now we are talking about clinical remission in asthma. Of course, thanks to the biological therapy, that's now we can start talking about clinical remission. One thing that is very important, remission in asthma is usually different than remission in oncology. In oncology patient, when the oncologists talk about remission of cancer, they do talk that there is no longer cancer activity in the body and treatment is no longer needed. The clinical remission in asthma, it does not mean that asthma has disappeared or cured, but it just means that there is no asthma activity while the patient is on treatment. And when we look at the asthma activity, we are addressing four main domains, that there is no asthma symptoms. Most guidelines use ACT scoring more than 20. Japanese go more than 23, but most of the guidelines using ACT to have good asthma control, zero exacerbation, zero use of systemic steroid, and very stable and optimized lung function. But that should be maintained over 12 months. So not 3 months, not 6 months. This kind of no disease activity or no disease clinical presentation should be continued for 12 months. The question is, are we able to do that in asthma? And if you look at the studies, you would see that yes, thanks again to the biological therapy after proper phenoendotyping to the patient, biological therapy has led to achievement on the clinical remission in up to almost 20% of those patients. So those patients will have almost zero asthma symptoms, no exacerbation, no steroid usage. I'm talking about systemic steroid of course, and stable or normal lung function for 1 full year. And thus considered as one step important towards the total cure of asthma that we hope that one day, we will be able to reach that stage really in treating a bronchial asthma. My take home message to you, ladies and gentlemen, that guidelines now talking about the goal of therapy is to control asthma. And again, we can control asthma by controlling the inflammation of the airway. But unfortunately, we cannot change the asthma severity. Asthma severity is something genetic. Most asthma patients, they have mild to moderate asthma, but about 3 to 4 to 5% of total asthma patients, they might have severe asthma. Irrespective of the asthma severity, that's not the goal of our treatment. The goal of our treatment is to control asthma, either by using single drug in mild asthma, two drugs in moderate asthma, and three drugs or more in severe asthma. And when we talk about controlling asthma, this means that we need to control asthma symptoms and to prevent the future risk of exacerbation. And as I told you that now we have even moved forward towards trying to really achieve the clinical remission when we are dealing with those patients. Now, we learned from many studies that even in patients with mild to moderate asthma, targeting the dual pathway of inflammation might be necessary in those patients, specifically in those patients who have cytokine pathway has led to a better asthma control. Biological therapy is now a really revolution and evolution in management of asthma or really of severe asthma in those patients. And now many of those patients do have better asthma control. And about 1 in 5 can get the stage of clinical remission, which is now considered as very ambitious goal towards asthma cure in the future. And with that, I would like to thank you very much for your attention.
Thank you, Professor Idris. This was indeed a very interesting presentation. We started receiving feedback even from the attendees. We'll wait for their questions. We want to make the Q&A very engaging. Please do share your questions on the chat or in the Q&A box. Now, before moving to Professor Sastre, please, if we can launch the post-presentation polling questions, please. Again, thank you. What do you think now, after the presentation, is the primary goal of asthma management according to the guidelines? I remember it was 50-50 from the poll number 1 between reducing disease severity and controlling airway inflammation. Let's see now what the audience is thinking. Please give it like 20 seconds and then share with us the results. Thank you. And we'll wait for your comments also, Professor Idris, when we have the results to compare. What are the results? So we have an increase from the control airway inflammation, which is your main message from the take-home message. Any comments here, Dr. Idris?
Yeah, I totally agree with the 82% that this is what we are trying to do when we treat asthma. As I said, reduced disease severity is not yet a really an available tool. This is genetic determined, and we cannot change asthma severity, but our goal is to control inflammation in order to control asthma. I think some doctors mix between the severity of acute asthma attack and the severity of chronic asthma. Here, the lecture is about chronic asthma. The severity cannot be changed, and it's no longer a goal of therapy. The goal of therapy is to use medication to control inflammation and hence control asthma based on symptoms and exacerbation.
Thank you, Dr. Idris. Makes perfect sense. Please, can we launch the next question? We already have Q&A coming. That's great. So, at what stage of asthma treatment do guidelines recommend anti-inflammatory approach? So the most, it was all stages and then lower percentage for severe asthma only. Let's see what they all think now. Please give it like 15, 20 seconds and share with us the results. So great, we have already Q&A starting coming. Please keep the questions coming. So we had 71% before for all stages and 23% for severe asthma, 6% for initial stages only. Let's see now what they think. So an increase to 87% in all stages and a decrease in the others. So as well as expected, Dr. Idris, any comments here?
No, that's fine. I think that's very true. And as I mentioned, that really in asthma, really GINA guidelines, anti-inflammatory treatment started at step one up to step five is just like increasing the number of controller therapy, but it should start from all steps, all stages in asthma, starting from very, very mild asthma to severe asthma, and using only SABA. Ventolin is no longer accepted as a treatment in those patients. Very
Of
well.
course. Next and last question before giving the floor to Professor Sastre, please. So, treating dual inflammatory pathways in mild to moderate asthma leads to no change, better symptom control only, better inflammation control, and asthma outcomes, increased side effects. So, in the pre-presentation question, we had a 92% for better inflammation control and asthma outcomes. Let's see now if it will increase or what it will happen. Let's give it like 10 more seconds and then share the results. So, do you have any results? So also an increase, even though it was already high, it's really reinforcing what the dual inflammatory pathways lead to. Any final comments, Dr. Idris?
No, I think there's almost consensus here, so that's great. That
That's
that I
great. Thank you so much. Professor Sastre, everyone is very excited for your session. We know how communication style and even patient-centered communication is very important in asthma. We know already that you have published articles about motivational interviewing in asthma, so we are very eager to hear from your experience and your practical advice. The floor is yours. Thank you for being with us today.
Well, good afternoon, and thank you all attendees for joining this webinar. And also want to express my grateful to Organon for inviting me to this forum. Well, this talk is quite different to the previous one because we are talking about behavior, feeling, thoughts from our patients, how to modify in those cases. So I think this an issue is a very rare issue in talks about asthma.
Professor Sastre, can we
Yeah.
launch some polling questions before the
Okay.
presentation? Yes. So please, can we launch the first question for Professor Sastre, please? It's just two questions, okay? We won't take it long. So the first question, it's about please rate your communication skills before attending this webinar. So we ask each and every dear doctor with us to rate his communication skills now, from 1 being poor to 5 being excellent. Please give it like 15 seconds and then share with us the results. Please vote on, some people are writing the rating. Please try to vote on the poll so we can collect the percentage. Click on the number that you see fit. Can we check? So we have most people rating between 4 and 5, which are great as a rating for communication skill. Let's see what they think after the webinar. Can we see the question number 2 for Professor Sastre, please, presentation? So this is related to motivational interviewing in detail. Let's, no, not this one. So the question is, how would you rate your understanding of motivational interviewing techniques? If you can launch it, please. It's the second question before Professor Sastre. So, how would you rate your understanding? Okay, it disappeared.
No.
How would you rate your understanding of motivational interviewing techniques from a scale of 1 to 5? So 1 being very poor to 5 being excellent. From 1 to 5, how would you rate how much you understand of motivational interviewing? And let's see what you think after the webinar as well. It's so fast. Okay, please keep the question longer because let's keep it for 30 seconds. We are not able to select, they are saying. The audience is saying they are not able to select for this question. Can you please try to launch it again? Yes, we'll take more time. So, how would you rate your understanding of motivational interviewing technique from 1 to 5, 1 being poor and 5 being excellent? So, if there is enough voting from your side, please can you share? So about how much they understand of motivational interviewing here. Okay, I cannot see again. Here we have like a variety of one being 3%, 2 being 14%, 3 being 29%, 4 being 31%, and 5 being 23%. Here we are very excited to see what they think after your presentation. The floor is yours, Professor Sastre.
Well, thank you. I try to show that some communication skill may improve at the end the quality of life of our asthma patient. Okay, this is my disclosure, and these are the objective of this talk is first to define what is this motivational interview, to understand why it could be important in the management of asthma patients, different techniques of motivational interview, and also review the evidence for effectiveness of this communication skill, right? And consider other type of intervention to modify the behavior of some patients. What's motivational interview? Well, it's a method of communication. Motivational interview try to understand all about our patients, not just the asthma, the illness, is understand the expectation, the beliefs, how our patients understand their health problem. It's not just explain the disease, it's just to understand just the behavior and why the behavior of this of some way of our patients. This is probably the main issue to understand motivational interview is to enhance the patient's motivation. What for? For a commitment to change, a commitment to change the behavior. In this case, now we are going to see that this is more applied for compliance in case of asthma with medication, right? This is the main issue is commitment to change. Can be practiced in different ways. The most common is face-to-face, but we can use another tools like electronic software, social media, another kind of intervention. Probably we are get used more to face-to-face interviews. Just to say that motivational interview started around 2010 and developed by Miller and Rolnick mainly to treat drug addiction, and now has been exported to other chronic diseases, including asthma, right? Which are the core principles of motivational interview? So first, to create a good atmosphere with the patients, comfortable, non-coercive, and try not to judge to the patient. This is quite important. So we need to break the ambivalence of the patients and move to action. This is also the goal of the motivational interview, the commitment to change that we mentioned before. So probably it is particularly relevant considering compliance in asthma medication. And the core principles also include the first, express empathy, so using reflective listening. You may develop this discrepancy between patient's goal and the current behavior of the patients, trying to show the discrepancy. Role with resistance, but avoiding always confrontation with the patient, right? And try to support the self-efficacy. I mean, trying to build a confidence in change on our patients, the confidence to change. So if we compare motivational interview with other traditional approaches, the more traditional approaches are self-managed programs and asthma education, right? And both may increase the knowledge about the disease, but not always have a good approach to increase the compliance with asthma medication, right? So may help, but always do not improve the compliance, right? So why to use motivational interview in asthma? You know, the compliance and the effect of the compliance on asthma control, you know, is quite important. And like any other chronic diseases in general, compliance in asthma related to medication is around 50%. Then we can discuss if how to consider a good compliance in the era of use of combination of ICS, LABA, in terms of as needed or not, but okay, we can discuss later. But as I mentioned, the traditional educations fail to improve the adherence. Probably is this motivational interview support and help more to a change of in the behavior of the patients, and also promote patients' autonomy, right? Which patients with asthma may benefit more of this type of intervention? Of course, patients with poor adherence to drugs in general, ICE of biologics, patients with fear of side effects, mainly to steroids, or smoking-related asthma problems. Also, patients with poor symptoms perception, right? And patients with over-reliance and only on use relievers, but no controllers, or patients who had emotional or psychosocial factors that may affect the management of asthma. It's true that not all patients may benefit from this approach, no? This type of communication. Again, the spirit of motivational intervention is to create a partnership, do not based on persuasion, acceptance, not judgment, compassion, not pressure, evocation, not imposition, right? But you know that it's required time, and try to understand really the patient, not just the disease. Which are the more common techniques used in motivational intervention? This is the so-called WARS model. WARS, because the O is trying to use so-called open-ended questions. That means is ask to the patient question and avoiding just the response yes or not. Try to promote in the patients more wide response, not just yes or not. Try to use affirmation or a statement of appreciation to the patients, right? So it's important to build and maintain a good rapport, a good relationship with the patients. Also, to use a reflective listening. So try to understand the patient's personality and try to emphasize the positive statement of the patient, right? And also at the end of the motivational interview, after question, affirmation, or reflective listening, try to summarize. All that we try to modify into the patient's behavior, right? So are longer than reflection to make a recap of the main strategic point, no? To reinforce the points and motivation to change. This is one of the techniques recommended. There are also other tools that are quite similar, the so-called RACE. So for say that relationship is first, advise, not judge. try to use I mean when also the doctor should use the I also have problems or I also, so this is the so-called use I statements. Try to support the patient's autonomy and also express empathy. So, uh, for example, these are a practical example of with a patient with poor adherence. So, try to use open questions. Say, if the patient have forgot the use of medication, inhaled medication, the question to the patient should be, tell me more about your routine. So that requires an elaboration from the patient, right? Or the second, try to make a reflections about why use or not the medication, etc. So and then try to make a recap and explain, try to get a response from the patient, not just yes or not again. For example, ask why might be the benefit of using the medication daily. So motivational interview, try to avoid just make an advice before the to explore the patient's perspective, avoid pressure versus invited to change, and also failing to acknowledge the patient autonomy. Think that the patients have not enough autonomy to treat, to manage their asthma. Well, now, having said that, we're going to review the evidence. I asked to ChatGPT about motivational interview, and what are the summary of response. But in case of asthma, say that motivational interview improve the adherence, and maybe better than the education alone. And the response to the result of the meta-analysis, they write that have large effect on adherence. As you know, ChatGPT is usually very optimistic in everything. So we're going to review the evidence. There are 11 studies related to the effectiveness of motivation interview in asthma. The quality is quite variable. First, not all use a randomized design, a valid instrument to measure the adherence. Four studies from 11 use one or more validated instruments and with internal validity. So, for example, to check by electronic way the medication monitoring. 9 from 11 study use a convenience sample. So that means that to generalize the results could be difficult. So this is a bias of many of the studies related to motivational interview in asthma. And also in these studies, they do not mention the expertise of the professionals that made the intervention. So if we review the evidence, the studies, see the intervention is quite variable: 6 months, 1 year, weeks, month, weeks. And what's the clinical outcomes? No significant improvement in clinical outcomes. Well, decrease of asthma symptoms, decrease of asthma symptoms, no significant improvement. 1 month, improvement in some clinical outcomes, improve in pulmonary function, but only 2 weeks, and some improvement in clinical symptoms. This use the classical or traditional motivational interview in a person face-to-face sessions. But there are another studies using the not traditional methods, and you see this is longer intervention, 12, and you see, well, decrease of asthma symptoms, no difference between groups, the control group and the intervention groups, just decreased asthma symptoms, no improvement in clinical symptoms. So, frankly speaking, ChatGPT again was very optimistic. But when you review the results, so limited promising results in trials using motivational interview. As you see, the duration was quite different. The length of the intervention also is quite different between the study. Although it seems that the longer duration, better results. But when you analyze the compliance in asthma medications, there is not any significant results. So I think that do not increase the compliance. Okay, it's true that in journal, in studies, participants reported increase in self-efficacy and confidence in managing their asthma, but also their skin. And also it's described that using motivational interview, patients easily engage in primary care, also done by specialists, but they engage better in primary care, right? So, well, apparently it's maybe useful, but when you review the evidence of the efficacy, is not so good. So probably motivational interview cannot be alone to improve some behavioral change in patients. So it's recommended go along with other type of intervention. And what type of intervention? The more study is the cognitive behavioral therapy. And this could be applied overall in patients with anxiety and depression. As you know, in the population of asthma patients in general, they have more anxiety and depression than the general population. So could be a good target. Why? Because the patients mainly with anxiety, but also depression, when the fear overwhelms the medical evidence that the evidence that you tell to the patients. So they have their belief change, and they affect the management of this patient. In this case, the management of asthma in these patients, and how to change the behavior. I mean, motivational interview is not the best way, and probably this so-called cognitive behavioral therapy is also better in patients with you need to change the evidence, the feelings of the evidence that the patient have. So may facilitate the understanding of the risk of the patient's belief and behaviors, right? And there is one study that combining both motivational interview and this cognitive behavioral therapy have better results. Although there are, frankly speaking, few studies, right? So what is really cognitive behavioral therapy is try to convince patients that their feelings are not facts, and the convince to the patient that they may correct the fear to this response to their illness, in this case, asthma. I don't know if I to explain myself, but it's noisy. And maybe all of us do this every day with our patients, with thinking that we are applying cognitive behavioral therapy or motivational interview. We do every day, but without to know that have this title. And that's it. Thank you very much for your attention. I'm ready to try to ask all questions.
Great. Thank you so much, Professor Sastre. Please, can we launch the polling questions before attacking the Q&A session? We started receiving many questions. I'm receiving it directly here. So how about rating your communication skills after attending the practical tips and tricks that Professor Sastre just shared? From 1 being poor to 5 being excellent. So before we had 16% rating 3, 40% rating 4, and 39% rating 5. Let's see their assessment now. So the same, almost similar, yes, 9% for 3, 48% for 4, and 43% for 5. Can we launch the second question, polling question, please? How would you rate your understanding of motivation and interviewing techniques from 1 to 5? Let's give it some time. Okay, can we check now for the responses? I can see it was okay. That's a big improvement. We were at 3%, it became 0. We were at 14%, it became 0. At 3, we were 29%, it became lower at 9%. At 4, we were 31%, it increased to 52%. At 5, it was 23, it increased to 39. So it seems, Professor Sastre, that your session really impacted the audience and increased their understanding of motivational interviewing. One last question I would like to share and then open for your comments, Professor, and then the Q&A session, which is very busy till now. The last question of the polling, please. The last question, do you plan to change your communication style? If you can launch it, please, Jim. Do you plan to change? Okay, I cannot see it now. Do you plan to change your communication style based on what you learned? So yes or no? This is a call to action for all of us on how we communicate on a daily basis. Please, let's give it 30 seconds for everyone to collect their answers. Okay, can we check the results now? What do the audience think? So, yes, 95%, 5% saying no. That's a great result, honestly. For your final comments, Professor Sastre, before tackling the Q&A, what do you think about the polling, about the overall session?
Well, first, we have a general problem in the world. For example, in our School of Medicine, there are, about communication skills, not for asthma, for any diseases. In general, nobody talk about, nobody teach about communication skill with our patients. We need to learn by ourselves after years of practice medicine, any specialty, any primary care, any specialty. Mm-hmm. And it's true that, the self-learning sometimes is not the best, but because in general we try to do the best and try to modify thoughts, feelings, behavior of some patients, not all, of course, but nobody teach our different techniques of approach. Probably only in psychology, psychiatry, but frankly speaking, probably many of us are doing this type of motivational interviews every day, but without know that this is motivational interview. That's also, I think, is
yeah, true. Thank you so much. Let's go straight in the Q&A. First question is for Professor Idris from Dr. Ala Sherbini. Thanks for the great presentation. My question is, can we use air supra albuterol budesonide as needed together with Symbicort budesonide formoterol as maintenance twice daily only approach? This is for you, Dr. Idris, and then maybe for Professor Sastre, if you would like to comment.
Thank you, Dr. Ala. In general, yes, you can. There is a study showing that mixing inhaled steroid is not harmful, but just on the sake of the cost, I'm not sure why this choice would be chosen if somebody is using Symbicort. Because if somebody using Symbicort, then they can use Symbicort itself as a reliever, because as you know, budesonide is as fast as really albuterol. Uh, I'm sorry, uh, basically formoterol is as fast as albuterol in really inducing bronchodilation. So generally speaking, we don't do that. So if you would like to use the alternative approach or really track while somebody is using Symbicort, then we use Ventolin. But we always prefer that once formoterol is used, including whether we are using Symbicort or Foster, which is beclomethasone and formoterol, to use the same inhaler as a PRM. But to answer your question, is it like safe and is it can be done? Yes, it can be done, but the cost will be almost double the cost.
Great. We have another question, maybe for both of you. We'll start with Professor Sastre. Myth, all the chronic cases like asthma are not fully treatable. Is it correct? Is there any alternative medicine approach like homeopathy? This is from Dr. Manjunath.
Well, not to my knowledge. Not to my knowledge. There's no alternative. But let me tell my opinion. Probably in our countries with similar healthcare, I mean, with free access to medicines, an easy way to access to specialists. I think that now the problem in asthma is not the under treatment, is the over treatment. I mean, I think that many patients are over treated, and we don't have a classical schedule of decrease the medication. So I mean, we're using high doses of everything just in case, but some patients do not need so much medication. And in fact, sometimes some non-compliance patients, strictly say non-compliance patients, are very well controlled, no inflammation in terms of FeNO or sputum, well controlled, no exacerbation, and they use only once a day the inhaler that apparently you need. I mean, apparently is the prescription is twice a day. So this is a non-compliance patient, but it's very well controlled. So because we don't, I mean, the step down is not done by many patients, by many doctors, I'm sorry. So this is my feeling in our developed countries with free access or easy access to specialists to drugs.
Yeah.
It's just an opinion.
Any comments from your side, Dr. Idris?
Yeah, I totally agree with Professor Sastry. Just like we know that asthma is like any other chronic disease we have now is incurable. However, spontaneous remission has been reported. We know that children with asthma, a significant percentage of them, asthma will go into spontaneous remission at the age of 13 or 14. Few patients with adult asthma, they might get spontaneous remission, but that's reported with cancer, that you reported with really other diseases, and we don't understand why or how that happened, why the body basically decide to cure the disease by itself. Having said that, we don't have ourselves cured for asthma. As I said in the talk, that even with biologics, only 20% of the patient will reach the stage of full clinical remission. And clinical remission means no disease activity on treatment. So to answer your question, no, we don't have a cure for asthma. There was some studies really addressed whether some really meditations, yogas, or those kind of really technique can help. That's beyond me. I don't know the answer to that. You need to ask basically the spiritual people who are in charge of this. But I would say that asthma is chronic disease and require chronic probably lifelong therapy. So, unfortunately, no, we don't have a cure for asthma unless clinical remission or really spontaneous remission happen by itself, and that's most likely to happen in children rather than in adults.
Thank you, Professor Idris. Another question for you we just received from Dr. Nahid Al Ghazali. Patient in life threatening asthma, intubated on vent now. From this point, how to manage? Another question also, at what clinical point to decide it's not reversible asthma? So first about a clinical case with a life-threatening asthma, how to manage, and the second about not reversible asthma. What do you think?
So, so here the question by Dr. Nahid is about somebody in acute asthma in the emergency room presented with near fatal asthma, and now the patient is on the mechanical ventilation. Now, actually, if you like, really ICU doctor about their worst nightmare, they would say asthma patients on the ventilator. And the reason behind that, that because of the significant, basically, really intrathoracic pressure and the auto PEEP, you need to use very high pressure controlled ventilation system in order to really push the air in, and that usually causes a lot of barotrauma. Personally, I've seen patients with 5 chest tubes on the ventilator with near fatal asthma. Having said that, ventilator sometimes is necessary in those patients whom you cannot reverse the acute asthma attack. And usually, if you ask ICU patient how to deal with those patients, most of them, they will really paralyze those patients. Uh, they're going to allow for basically permissive hypercapnia, try to use low respiratory rate, trying to induce basically prolonged expiration. And the only way to do that is really when you really heavy sedate and paralyze those patients. So this is a really clinical scenario that's dealt with within the critical care basically room with an experienced really intensivist with a pulmonologist dealing with those patients. Again, it's very difficult cases, but luckily, patients hopefully can survive this. The second question is regarding when should we call asthma really irreversible? That depends on the question. If you look about the definition of reversibility generally in asthma, that's what we do in the lung function lab when we use spirometry and then we use a bronchodilator to assess reversibility. We kind of define reversibility as improvement in FEV1 by more than 200 ml with 12% improvement really in the predicted values. However, if you're talking about chronic irreversible airflow obstruction that happen when you have chronically uncontrolled inflammatory asthma, when you get chronic really remodeling process, and there's a lot of fibroblasts uh, really upregulation in the airway, leading to airway thickness and airway really fibrosis, very thickness of the basement membrane. So this is considered as very, very advanced stage of asthma, usually as a sequela of chronically uncontrolled inflammatory asthma, and it leads to fixed airflow obstruction, very similar to the COPD patient. So those patients, basically because their muscle get fibrotic, the airway get fibrotic, there's no longer having reversibility. And that's what we call at this time airway remodeling process, that there is now a lot of study trying to see if biological therapy can really attenuate that process or reverse it. Until now, we do have some data to show that biological therapy can attenuate and partially reverse the remodeling process, but will it be complete reversal? That's yet to be determined.
Great, thank you so much. I'm sorry, I know we have reached the end of our session, but we'll continue for a few questions if you don't mind, professors, because we are still receiving a lot of questions. A question for Professor Sastre. We know that the clinicians have very little time usually in their clinic. How can motivational interviewing be effective in brief clinical encounters?
And I totally agree that every day we have less and less time to interact with our patients. That's a problem. Absolutely. So probably it depends on each patient, but it's difficult to modify the behavior in general, the motivation to the patients in few minutes. That's true, and it's quite difficult. But let me just say, uh, short comment. Think about asthma control, right? And if you review the definitions in HCT or ACQ or GINA, based in symptoms, based in the use of relief medications, just think that patients with anxiety may have more symptoms, more use of rescue medication, problem, with sleep. And these patients with under control, with no control, the control do not increasing the medication in just is treating anxiety. This is the key point that sometimes is tricky just to talk about asthma control and probably think more about mainly anxiety in patients, but the anxiety is not treated with medication and with. So, yes, I would like to say this comment.
So even in a few minutes, maybe like the change of how we communicate might make a change on the patient outcomes, even in short time. We might be
But
able.
at least if you detect anxiety,
Yeah,
it's very easy. At least, I mean, send to a professional,
yeah.
psychologist, psychiatry, that they know how to handle better than us
Mm,
the anxiety.
yeah,
Because the very bad control, a severe disease, of course, increase the anxiety. I have some papers about if you improve the asthma control, improve the anxiety and depression. But it's more common the opposite. The
yeah,
anxiety increase the under control of asthma, but the anxiety, the treatment of anxiety is quite different.
yeah. Agree. More questions coming for Dr. Idris. What is your advice on repeating? Okay, the question disappeared. Please, if you can put it back again, or let me check in the answer. What is your advice on repeating oral corticosteroid courses more frequently in patients with asthma, and what are the risks of long-term use? From Dr. Ala Sharbini.
Thank you, Dr. Ola. Actually, this is the problem, uh, and the single most important advantage of using biological therapy is to reduce the need for repeating courses of oral steroid. We have many studies. One of the good study came from David Price and his team looking at if your patient receive more than 1 gram of steroid lifetime, 1 gram of really steroid, there is will be doubling or tripling the long-term sequela. And of course, if you're talking about 1 gram, so if you are when we treat patients with acute asthma, use for example 40 milligram for 5 days, so that's 200 milligram. So 4 or 5 courses lifetime will lead to doubling or tripling of the chronic side effect of the steroid, including myocardial infarction, pneumonia, osteoporosis, cataract, and bone diseases. So having courses of oral steroid is very toxic. Sometimes we have no choice but to use oral steroid once asthma is exacerbated. But really, all that we need to do by using really multiple anti-inflammatory therapy, including biologics, is trying to reduce the courses of systemic steroid that patient uses because of uncontrolled asthma. So the answer to your question is we should do everything possible to prevent that from happening because we know that as low as 1 gram in lifetime will lead to the drastic long-term complication in those patients.
Thank you so much. Another question for you from Dr. Muhammad El Kaba. In asthma exacerbation attack, combining parental methylprednisolone and inhaled budesonide is beneficial, or IVICS is enough besides short-acting bronchodilators.
Thank you so much. The role of the inhaled um, steroid, high dose inhaled steroid used in acute asthma is more established in pediatric. And it's been a strategy used in pediatric patients with asthma to kind of avoid using parenteral steroid. Are really in those patients. In adult patients, the benefit of the inhaled steroid, besides systemic steroid, is very, very really subtle. Most people they use that routinely, but really, if you look at the outcome, uh, it's not very well established. Although there is some study to show that if you use high dose inhaled steroid beside systemic steroid, you reduce the recurrence of asthma attack over the coming 30 days. However, those studies were small and kind of inconclusive. So I would say that if you use enough systemic steroid in acute asthma, plus a lot of, and that's I think the magic word, a lot of bronchodilator, and I'll say this is the trick of success in acute asthma to prevent deterioration is to use Ventolin back to back or continuous over 1 hour in order to break this really bronchoconstriction event. So I think the cornerstone will be too much Ventolin initially with systemic steroid. If you decided to use some inhaled budesonide or inhaled steroid, that's fine. That's been shown to have some benefit, but it's mostly in pediatric, not in adults.
Great. A question from Professor Sastre. This one is anonymous. How the clinicians can measure the success of motivational interviewing intervention in asthma care. So how to measure the success of their intervention?
Probably using asthma control, no, questionnaires and quality of life questionnaires.
Yeah.
This is the main outcomes uh, to measure the success of this type of communication skills. Similar to medication, to the
Yeah.
success of medication.
Great. A question also anonymous for Dr. Idris. How can we treat dry mouth secondary to steroids inhaler?
Good question. So if you look at the side effect of the inhaled steroid is usually local, which is really dry mouth, candida infection in the throat, sometimes dental changes. So I think the trick is two things: is the oral hygiene after using the inhaled steroid. So those patients should kind of gurgle very well, not only mouthwash, just like gurgle, gurgle, gurgle very well, and then really spit it out. Some people do really brush their teeth after that, but it's really very important if you brush your teeth to change the toothbrush frequently because that toothbrush will get a particle of the inhaled steroid, and if you keep using for a long time, it can really affect your teeth. So we always say that keep one brush to be used after inhaled steroid and keep one brush for usually regular dental basically hygiene. The other question beyond this local side effect is sometimes, as Dr. Presley said, that Sastry said that sometimes we are overdosing our patients. So if you are using high dose inhaled steroid and the patient is doing well, probably one way to overcome that is to cut on the dose of the inhaled steroid if that's okay clinically if the patient is doing well. So maybe you don't need to use that dose of the high oral steroid, and that should help your local side effect. At one stage, there was this molecule of the inhaled steroid called cyclisinide. Unfortunately, it's no longer available in Saudi Arabia. That molecule get activated when it gets down into the lung, so it has minimal side effect in the mouth, which we used to use in those patients who have a lot of local side effect, but at the moment, we don't have it in the Saudi market.
Okay, good to know. Great. Professor Sastre, another anonymous question. What training or resources are available for the HCPs to develop their skills in motivational interviewing? Is there something available for them to develop the skill?
Uh, well, there's no guidelines like other classical guidelines,
Yes.
treatment or diagnosis or something like that. Uh, I show you some recommendations, right? Trying to convince, how to convince the patients to change,
Hmm.
not in terms of the fear to side effect of steroids or whatever. Is trying to, I mean, first try not to judge to the patients, try to have empathy. So you can read a publication that mentioned that are the doctors who started with this type of communication skill, no, the motivational interview that was adopted first for treatment of drug abuse, for drug addiction. So it's not so easy. Apparently, it seems it's common sense. It's common sense, but probably we need more training by specialists.
Specialist, yes. Great. Good to know. Another question from Dr. Ala Sherbini. Can we combine salbutamol, ipratropium, atrovent, and budesonide together in the nebulizer for treating an acute asthma attack in the ER setting?
Uh, you can. Actually, what we do in those patients who have severe asthma, we use combination of salbutamol and ipratropium in the initial hour back to back. As I said, in our center, we don't use a lot of really inhaled steroid in adult to treat acute asthma, but we use Ventolin, ipratropium, um, um, basically back to back every 20 minutes for 1 hour, and then we reevaluate. So yes, you can combine these different molecules together. There'll be no problem if you would like to use that.
Great. Just one note for all our attendees, because some questions are related to CME accreditation. So I would like to say that this webinar is triple CME accredited by the SFDA in Saudi, by the UK CPD for the Gulf and other countries, and by the SAMA for the South African country. As you know, here we are all here from the META region, so Middle East, Turkey, and Africa. All of us are here, and this is why we try to accommodate everyone with the CME accreditation. For the numbers you are seeing in the chat, only the KSA doctors are required to fill the link that we are putting in the chat to acquire their CME points. The others, so the UK CPD and the SAMA, will not require any link filling. You will directly receive the accreditation into your registered email. And also, this webinar is present on demand, not just live. So every person who missed a part or all of the session can view the recording. Also, it will be sent by mail. And even if you view the recording, then you will be able to acquire your CME points. Sorry, I'm jumping here because many questions are related to CME accreditation. I cannot see more questions. Please let me know, the audience, our dear doctors, if there's any question, we'll be happy to take it. I would like to thank both the speakers. Before concluding, I would like each of you, our guest speakers, to say one final message, a take home message to the audience that is from you. We start with Dr. Idris.
Okay, thank you, Noor. I would say my message to the audience that asthma is nothing but inflammatory disease. Treatment should always be based on controlling the inflammation in order to control the disease. And we at no stage we kind of compromise of using anti-inflammatory treatment, whether monotherapy in very mild asthma or combining anti-inflammatory medication in order to reach the stage of fully controlled asthma and hopefully to the stage of clinical remission. Thank you.
Thank you, Professor Idris. Professor Sastre, one final message from you.
That we need to improve our communication skills with not all patients, but some patients try to change the behavior, beliefs that may affect the control of their disease, in this case, asthma. And also think about anxiety in patients with no well-controlled asthma. That is also a treatable treat. I think in patients with asthma.
Great. Thank you so much, professors. This was really interesting as we tackled in the first part asthma management, and second, we tackled how we communicate with patients and how we improve outcomes. Both of these presentations are very important to achieve better patient outcomes for all the asthma patients in our region. Again, I would like to thank you so much for your valuable presentation and insights. I would like to thank the audience because it was a very interactive session. Every poll was answered by more than 100 attendees. So we're really thankful for all the audience because they were really interactive. They asked some great questions, and we hope that this session was informative for them. Thank you so much and have a great afternoon.
Thank you. Bye-bye.
Thank you. Good afternoon from Madrid.
Okay, adios. Adios.
Adios.
Bye-bye.